In this presentation, we will discuss different factors that should be considered when treatment planning and restoring endodontically treated teeth. Perhaps one of the most important factors to consider when treating these patients is restorability, as well as long-term prognosis for those teeth. Take this patient, for instance, who was referred to prosthodontics for a full fixed rehabilitation of their mouth. Tooth 1-5 was restored endodontically before referring the patient. If we wanted to fabricate a bridge between the canine and the second premolar, we likely would need a post because there's not a sufficient amount of tooth structure remaining above the margins. Most of the actual walls would be in restorative material and ferrule would be inexistent. This would mean that a bridge at the proper occlusal plane would probably cause too much forces on such a small root, and the prognosis would not be very good. This is why for this patient, the decision has been made to extract the tooth and place implants instead. Of course, extraction is an option, but in a lot of situations, retaining the teeth will be better for the patient. We will discuss when a tooth should be retained or extracted. It has been shown that the survival rate of dental implants is lower than the survival rate of natural teeth. For implant, we expect the survival rate to be in the range of 95% at 10 to 15 years, whereas for teeth that are periodontically healthy, the survival rate is much higher. The complication rate on dental implants is also much higher than the complication rate on natural teeth. A consensus was reached in 2008 when multiple experts did review the current literature on dental implants, and they concluded that dentists should consult patients to retain their teeth. They also saw that teeth should always have the priority whenever possible unless multiple risks were present. They concluded that oral implants are the last resource. They should not replace teeth. They should replace missing teeth. Different patient-related factors could justify keeping teeth that have a questionable prognosis. For instance, patients with systemic conditions or younger patients. For instance, 20-year-old patients may prefer to keep a natural tooth for a few more years before the extraction and hope to keep a fixed restoration for a longer period of time in their life. Let's say the patient was to live to 90 years old. We do not know if an implant will stay in that patient's mouth for 70 years. And therefore, keeping the natural tooth until it has to be extracted could be a better long-term option for the patient. The cost effectiveness might vary depending on the treatment chosen. In 2009, Pennington made a Markov model to evaluate the cost effectiveness of a root canal treatment for a maxillary incisor tooth with a pulp infection in comparison with the extraction and replacement with a bridge, a denture, or an implant-supported restoration. The model was built to simulate the lifetime path of restorations placed on the maxillary incisor following the initial treatment decision. The model estimates a lifetime cost and the total longevity of a tooth or an implant-supported crown at the maxillary incisor site. The model considers the initial treatment decision and the various subsequent treatment decisions that might be taken if the initial restoration was to fail. The model also assumed that a post and a core and a crown was necessary. The model calculated the probability of the incidence of all significant mechanical and biological complications that might arise in each of the treatment options over each 6-month period of the patient's life based on existing evidence. A repair event or no event occurring meant that the simulated patient remained in the same restoration state, whereas a complete failure resulted in transition to a different treatment option. For instance, the event of a root fracture would require the extraction and replacement with another option. Different conclusions were made. The first one was that a root canal treatment, post and core, and a crown is highly cost-effective as a first-line intervention. The orthograde retreatment is also quite cost-effective if a tooth treated with a root canal treatment was to fail. The surgical endodontic retreatment, however, was not cost-effective. Obviously, those conclusions are not intended to be clinical guidelines, as each patient will vary. Also, the study is a little bit old, and different evidence might be different for surgical intervention, for instance, and the prognosis could be better nowadays. But this data does help clinicians discuss the long-term cost and best values for the patients. The aesthetic outcome of the restoration is, of course, important to consider. Esposito randomized 40 patients in a group where the tooth would be either endodontically treated and restored with a crown, or extracted and restored with an implant restoration. The pink aesthetic score and white aesthetic scores were evaluated for each of those patients. The pink aesthetic score pertains to the soft tissue around the restoration. A better pink aesthetic score means that the soft tissue around the restoration was more aesthetic. The white aesthetic score is the aesthetic value of the restoration itself. Now, for those patients, the pink aesthetic score was significantly better in the endodontically treated tooth, whereas there was no difference for the white aesthetic score. Let's discuss prognosis. To ensure a good prognosis for the restoration, it is very important to have a good seal. Reintrope, in a classic study, evaluated the effect of the quality of the restoration and the quality of the endodontic treatment in terms of absence of or presence of a radiologic lesion. If the restoration itself was well sealed, in 67% or 91% of the cases, there was no endodontic lesion. If the quality of the endodontic treatment was good, but the seal of the restoration was bad, in 44% of the cases, there was no lesion. And of course, if the endodontic treatment and the restoration were both bad, in only 18% of the cases, there was no endodontic lesion. So teeth that are restored endodontically. If they get a crown, we know that the prognosis is quite good. At 10 years, the survival rate is about 81%. if we only have a restoration, a direct restoration, be it composite or amalgam, about 63%. Aquilino found that teeth were lost 6 times faster if they were not crowned after endodontic obturation. Now, is that the same for anterior teeth? This is important to consider. Anterior teeth, we know that a crown will not make it better. So Sorensen in 1984 did a classic study where they saw 3 quite interesting conclusions. The first one is posts do not reinforce teeth. All they do is they hold the restoration. If we don't have sufficient amount of retention for the crown, a post is required. Second conclusion was that crowned anterior teeth or uncrowned anterior teeth had the same prognosis. We could make sense of this by the fact that if we were to prepare the tooth for a crown in a lot of those situations, we will remove all the tooth structure remaining, and therefore the tooth could become a little bit more brittle, if you will. Of course, the crown might help, but the fact that we have removed more tooth structure, both combined together make it so that it's not better. But the third conclusion is that posterior teeth will have much better prognosis if they are crowned than if they are not. This conclusion is even more important for molars. If a molar was treated endodontically and a direct restoration was made, after 1 year we could expect that 96% of those teeth would survive. After 2 years, only 88% will survive, and after 5 years, 36% could survive, the rest may have fractured. Now, of course, if the tooth structure is good, the prognosis is better. Let's now discuss different risk factors that could change the prognosis of those teeth. Dentin moisture was discussed quite a bit in the past. Some authors concluded that the dentin would get drier after a root canal treatment, and because of that, the tooth would be more prone to fracturing. However, all newer studies did not see that effect. It is now known that dentin is not more prone to fracture, or it's not weaker after a root canal treatment. One variable that is very important is the remaining tooth structure. Rhee in 1989 compared the fracture strength of different restorative design. They compared a non-altered tooth, a tooth that had an endodontic access preparation, a full root canal treatment, just an occlusal cavity preparation, a two-surface cavity preparation, be it a MO or a DO, a three-surface MOD cavity preparation, or a three-surface MOD cavity preparation plus a root canal treatment. And their conclusions were quite interesting. If we compare the unaltered tooth with that tooth having an endodontic access, or a MOD and a MOD with a root canal treatment, what we can see is that the difference is only 5%. What is really important is not the fact that there is a root canal treatment or not on the tooth. It's the amount of remaining tooth structure. If the tooth has an MOD preparation, the strength of that tooth is decreased by about 63%. This is what is very important, not the impact of the root canal treatment itself. Another factor that is quite important is the absence or presence of ferrule. If a post was used to restore the tooth, but no ferrule was present, that root would be at a high risk of fracturing. The reason why ferrule is so important is because ferrule will provide a certain amount of tooth structure inside of the crown that will prevent fracturing of the root. If we have vertical walls that are surrounded all around by the crown, the root could simply not fracture when load is applied to the post. To achieve this effect, a minimum amount of ferrule is necessary. Liebman in 1995 answered the question to what was the minimal amount of ferrule needed. They evaluated the resistance to fracture of different teeth with 0.5, 1, 1.5, or 2 millimeters of ferrule. What they did is they placed those teeth in a machine with a cyclic load and evaluated how many cycles of load they needed to apply on those teeth to fracture them. The teeth with either 0.5 or 1 millimeter of ferrule did fracture early, whereas with 1.5 or 2 millimeters of ferrule, those teeth were not significantly different than control teeth, which were not treated endodontically. And therefore, the strict minimum amount of ferrule that we should want to have before we do treat teeth with endodontic treatment and post before placing a crown would be 1.5 millimeters. This here is a situation where not enough amount of ferrule was used. This patient presented to me with a failed canine to canine bridge, which uncemented recently. If we look at the tooth preparations on both canine, we could see that not a lot of tooth structure is remaining above the gum level. The first thing that would be required to evaluate the long-term prognosis of those teeth is to remove the carious lesion and evaluate how much ferrule we really have. Now, I made that temporary restoration for the patient, and by doing so, I've evaluated the amount of ferrule. And of course, only a little amount of ferrule was remaining around those teeth. Therefore, the long-term prognosis is not going to be very good. It would be better to consider another option for the patient. We could either extract those teeth and restore with implants, or we could do crown lengthening or orthodontic extrusion. Crown lengthening is not always the best option. This is because by doing crown lengthening, we will also change the crown to root ratio. In different situations, because of this effect, it might make the whole prognosis to be just the same. In these two studies, the authors did not find any advantage in doing crown lengthening over restoring the teeth without any ferrule. Now, if we compare orthodontic extrusion and crown lengthening, we could see a different story. If I was to do crown lengthening, I will remove some of the periodontium to get that ferrule. If I do orthodontic extrusion, I simply extrude the tooth out, and then I could get the same preparation. So you see those two options, they give me the exact same root, but the key difference between them is the length of the crown. If I was to do crown lengthening, I get a longer crown, and therefore my crown to root ratio is not as good. So a better option for these patients, if it's possible, would be to do an orthodontic extrusion. Remaining tooth structure is really important as well. Take this example for instance. This tooth here had an endodontic lesion, as you can see on the x-ray. Now, a root canal treatment was done for the patient. After the root canal treatment was done, completed, it was decided to place a crown on that tooth. Unfortunately, the person who did that restoration ended up seeing that, well, they did not have sufficient amount of ferrule, and they decided to do crown lengthening to get more ferrule. Now, it's important to consider those teeth are conical. So if I was to do crown lengthening, I still won't be able to have more ferrule, because as I remove tooth structure and move more apical with my margin, I always remain in the gutch-burcha because the walls are not going to be thick enough to provide me with that ferrule. So this tooth doesn't have a really good prognosis. It's really important to consider this. If you look at the tooth before and after, do we think the crown will make things better? We should probably have considered the preparation, what it will look like before doing it, and stopped ourselves on the first image and decided, you know what, our best bet is probably just going to make a direct composite for that tooth. Another thing that we should discuss is the size of that restoration. If I had a MOD preparation just like this one, which is quite narrow and not too deep, we can make a crown preparation, we won't have any problem. Now, if the restoration was really big, such as this one, once I finish my preparation, even though I might see that I still have dentin on both sides, those dentin walls could be undermined by the restoration and really not reinforce the tooth at all. So it means if I was to make a crown on that tooth, I don't have much support. It probably would be better to do a root canal treatment on that tooth. So in a lot of situations, it's actually better to remove the restoration first to assess how much tooth structure do I really have, and then decide if we need a root canal treatment or not. In this situation, a root canal treatment would be advised. Other type of risk factors. The first one, cusp covering. If I was to do an inlay, or if I was to do an onlay or a crown, I will have a, with inlays, when I put some forces on the cusp, I could create wedging forces and the tooth could still end up fracturing. Whereas if I do a crown or an onlay with cusp coverage, then the forces will be vertical and the cusps will stay together. The number of proximal contacts is important too. A tooth that is embedded between other teeth will have better prognosis than if it was a terminal tooth that was restored. The number of abutments. For instance, a crown will have better prognosis than a bridge. If we have cantilevers, we are going to put much more forces on our restoration, on our roots, and the risk of fracture is increased. The position of in the mouth is important too. For instance, a mesial cantilever to replace a first premolar is not going to be as risky as a cantilever to restore a canine or a molar. Telescopic abutments are going to increase the risk as well. So telescopic abutments are abutments that are cemented on teeth, and then a removable appliance could be placed on that restoration. The problem with telescopic abutments is that they require more tooth structure than a crown, and therefore we have less tooth structure left for the success of that tooth. Abutments for removable dentures are going to change the risk as well. If I have a removable denture and that endodontically treated tooth was to be used in that removable appliance, the risk is going to be much higher on that tooth. Of course, those risks will be compounded. If it was a distal tooth and a removable partial denture was going to be done, well, of course, the risk will be increased. The position in the mouth is important too. In the maxilla, teeth are usually longer than in the mandible, and therefore the prognosis could be better for maxillary teeth. An anterior tooth will usually have a better prognosis because there's usually much less load on those teeth. The second molar, the upper premolars, both will have a worsened prognosis compared to all other teeth. And that has to do with the amount of tooth structure left, the furcations, and the amount of force that will be put on those teeth. Occlusion has a tremendous impact on the prognosis of those restorations. If a patient had a complete denture opposing endodontically treated tooth, not a lot of load will be transmitted to that tooth and the prognosis would be quite good. However, if the patient has a shortened dental arch or a unilateral occlusal support, then a lot more forces will be distributed to that tooth and the prognosis will not be as good. Interferences will be a problem too. If the patient had a good mutually protected occlusion, problems will be much less. If the patient had parafunction or clenching, then problems would be seen much more often. The type of patient is of course of importance. How strong the patient is will have a big effect. We always think of the big masseters, but some patients will be quite slim and they could still put a lot of forces on their teeth. The range of molar load in function is usually about 150 to 250 newtons, but the maximal clenching force will vary between 500 and 750 newtons, but could be as high as 1000 newtons. The individual on this picture had a biting force of 4,340 newtons, which is equivalent to 443 kilograms. Now, if we compare that to the world record super heavyweight snatch, this is only 213 kilograms. So as you see, this patient could put twice as much forces on their teeth as anybody on the planet could ever lift with their arms. The crown to root ratio, as we discussed earlier, is something quite important. If the patient had either a shorter root or periodontal problems, then because of the cantilever that would be created, if you will, on a shorter root and a longer crown, then more forces will be distributed to a shorter root, which has more chances to fail. Now let's discuss different other considerations. The position of the margin around the carious lesion before treating the patient is something quite important. If we were to treat those teeth, we will likely have to drop the margin apically, and because of that, bone will migrate apically as well. In some situations, the tooth will have an excellent prognosis and it could be justified, but in some situations, if the prognosis of the tooth itself is not very good, the impact on the adjacent tooth might be a little bit too costly for the patient. This case here is a case where we decided to restore the tooth, and what you can see is, of course, we lost quite a bit of bone after restoring the tooth. Again, if the prognosis was really good, then it might be all right, but if the prognosis is found to be limited, well, it might not be a good trade-off to lose periodontium on the next tooth. In some situations, the carious lesion is so big that restoration will be a problem. Take this tooth, for instance. If I was to restore it with a crown after the root canal treatment, that's what my preparation design would look like. And on the distal, my margin will be right in the gut burcha. So again, earlier we discussed re-entrop, where we saw that it's really important to have a good seal. Well, if the seal is just 0.8 millimeters away from gutta percha, the risk of reinfection might be much higher. The survival rate of natural teeth treated with endodontic treatment and single crowns is usually quite good. As you can see here, after 5 years, 94%, 10 year, 80% in terms of success. The tooth is still there, we just need to do another treatment, maybe a new crown because there was decay or something like this. The survival of the tooth is about 90% at 10 years. Now, if you were to look at this retrospective study here of 1,037 crowns, what we see is that vital or not vital didn't make a difference at 18 years. The, the survival rate was not different. Now, if we have longer bridges, non-vital teeth will have a worsened prognosis. If we have cantilevers, same thing, non-vital teeth will have a worsened prognosis. When making a post and core, we have to determine the length for that post. The rationale for using a post is to provide a retention for the crown. If we have sufficient amount of retention, we don't need a post. The disadvantage of putting a post in a tooth is we need more tooth structure removed in the root. We will put more stresses on the root, and we could potentially fracture. Now, if we add teeth with enough actual walls for retaining a crown, we would not need a post. If we have a tooth with a big pulp chamber, such as the x-ray we see here, we could simply place a core that is retained inside the pulp chamber. We would not need posts. The prognosis will be better for the tooth if treated that way. It's important to keep at least 4 millimeters of gutta percha. That's the strict minimum. It's recommended to keep 5 millimeters. We should use the smallest possible diameter for the post, again to preserve tooth structure. If we make the post too short, there will be much more load distributed on a shorter part of the root, and the stress might be too high, which will lead to tooth fracture. It's much better to put the post as long as possible while keeping an endodontic seal so that the stresses will be distributed to a longer part of root and therefore minimizing the risks of root fracture. Those posts here would be way too short. What type of post do we need? Should we do a prefabricated or a cast post and core? Let's say we have those teeth here. I'm going to do a root canal treatment. I have not much tooth structure remaining. Now I want to place that crown, and of course I plan to place a post. As you can see here, one of the restoration on the left has much more restorative material on the buccal, but not much on the lingual side. The risk of that core detaching from the post is quite high. Whereas on the right, we have a good amount of material on all sides of the post, and the core will be really nicely anchored to the core. So in some situations, because of the attachment between the core and the post, it might be a better option to do a cast post and core. If we have multiple roots in multiple canals and we decide to use multiple posts, the core will be quite well attached to the post, and that's usually not a problem. So prefabricated posts will work really well on posterior teeth, but on anterior teeth, in a lot of situations, a cast might be a better option. Now for aesthetics, what we could do is we could polish the buccal side of that post, and what it will do is it will reflect the light better so that we won't see the post through a ceramic restoration. When restoring teeth with prefabricated posts and a composite core, we have two ways to do it. We could either cement the post with luting cement and then place composite, or we could use a material that is going to be dual curable to cement the post and fabricate the core. If we were to use the latter option, we won't have a joint between the cement and the core, which might help with the attachment between the post and the core. Pins are also an option to treat those teeth, but in most situations, it would be preferable to place a post. In a situation like this one, where 4 pins were used, we could ask ourselves what the rationale was to even put a crown on the tooth. If no walls were remaining, then what was the crown really protecting? As you can see here, this crown failed because the pins failed. In situations where pins are the only reason why the tooth or the crown could remain on the tooth, then a post would have been a much better option. This type of case here would have a really low risk. If we were to think about using a pin to hold a restoration before making a tooth preparation, it would not be much of a problem. The reason being that we have a lot of dentin remaining to hold the restoration. The pin is not going to be instrumental to the success of the tooth. When we have forces going on that crown, we will have both the amount of vertical wall remaining on the side with the missing cusp, but we will also have a remaining cusp on the same side that will hold those forces, that will resist those forces. If we have the same exact situation with one cusp missing, but no vertical walls remaining, again, we will have quite a bit of dentin that could help us resisting forces. The pin will help, but not as much as the walls of dentin remaining. We could do the same situation and restore with a crown, but now the only part that will resist the dislodgement of the crown is going to be the cusp, which is probably going to be quite enough. Now, in other situations, such as when we have 2 cusps missing, the problem is a little bit higher. In this situation here, we still have some vertical walls that will be remaining in our restoration, and we could think that there will be sufficient amount of walls left for retention, and we will have an amount of vertical wall on the opposing side to resist occlusal forces, to resist dislodgement. The pins are going to be important to the success, but the wall of dentin that is going to be remaining could help resist fracture. That being said, the risk is going to be increased in this situation. Of course, with 3 cusps missing, endodontic treatment would be indicated. Now, the same situation, but without a vertical wall remaining. Of course, again, we could think that the vertical walls of dentin remaining will be providing some retention for the crown, but there won't be any resistance other than what is given by the pins. And in a situation like this, the occlusal forces might overload the pins. Once the pin will give up, the tooth will end up fracturing, and at this point the cusps will be lost and the prognosis of that tooth would be much lower than it is at the moment, and endodontic treatment is indicated. I will finish this presentation with a short presentation. This patient came to see me because they had quite a bit of pain. Now, things we could see on those x-rays, the first is there are quite a few endodontic problems with radiolucid lesions. We can see really long cantilevers. Again, cantilevers will give us a much higher risk for the patient. The teeth are posterior as well, the posterior most units are for the patient. And of course, we can see that the root is currently fractured. Now, why did this fracture? Well, all the risk factors we discussed are present in this case. We have a really long crown and a really short root. We have a really short post as well that is much shorter than even the crown. We have a really long cantilever that will increase the forces put on that restoration. And we don't have much ferrule left on that tooth. We have a really wide post and not much tooth structure remaining. And if we think about ferrule, well, we have a tiny bit of ferrule on one side, but on the other side, we actually have negative ferrule if such a thing exists. Because of this, the risk of root fracture was much, much higher, and this is what happened for this patient. And ironically, the last thing that we can see here is that the canal was not sealed, which might be why we were seeing endodontic lesion in a lot of those situations. In some situations, such as this one, we could ask ourselves, is it a good option to even treat the patient? An endodontic treatment was done for the patient, and a preparation was done. Now you can see on the x-ray that there's not much walls remaining. Actually, the red line here is where the gingiva was. So we don't have much tooth structure remaining above the gingival level. What we decided to do is simply to put a dome on this tooth. It looks like there's a carious lesion, but it's an artifact of the X-ray. This restoration will put less forces on the tooth than if I was to place a crown, for instance. Of course, we could think about, well, could we do orthodontic extrusion or a crown lengthening procedure for that tooth, but the furcation is already quite high, almost exposed, and any type of treatment to try to make things better may actually make things much worse. And using a dome such as this one might be a better option for the patient. I thank you for your time, and hopefully you enjoyed this presentation.